Welcome. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted, so you can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all to our guest speakers. Joining us today, we have Sarah D. Sarah is one of the physician assistants from the MGH Center for Neurointestinal Health at the Division of Gastroenterology at Mass General. She completed her training at Johnson & Wales University in Rhode Island. Joining us today, we also have Luyang Liu. Luyang is a physician assistant from the MGH General GI team at the Division of Gastroenterology. He completed his training at Mass College of Pharmacy and Health Sciences here in Boston. In recognition of Irritable Bowel Syndrome Awareness Month, they join us today to give a talk on Irritable Bowel Syndrome. So please join me in welcoming Sarah and Luyang.
Thank you so much, Amy, for that wonderful introduction. Just give us a minute while I pull up our slides. Okay, alrighty. So our title of our presentation is The Ins and Outs of IBS, or Irritable Bowel Syndrome. Go to our next slide. So neither of us have anything to disclose. And so our outline. So like our title says, we're going to be going through all the ins and outs of IBS today. So we're going to go over, what IBS is, the statistics, symptoms, causes, diagnosis, treatment, as well as some complications or implications related to irritable bowel syndrome. We'll also be going through a patient case together to give us a better understanding of how someone with IBS might present, and also give you a sense of what a patient experience is like with IBS. So in our next slide, we're going to start with our patient case. So in our case, we have a 50-year-old woman, otherwise who is healthy, no past medical surgical history, presents for evaluation of chronic, episodic, diffuse abdominal pain, starting since the fall of 2022. The symptom is often associated with the onset of diarrhea that happens at least once a week, but she reports no other symptoms, no nausea, vomiting, fevers, chills, or unintentional weight loss. She also hasn't seen any blood in her stool or has never passed any tarry stools as well. Her abdominal pain often improves after the bowel movement, but the symptoms sort of wax and wane without any clear triggers. She has no significant travel history, no recent GI viral or bacterial infection, no changes to her medication when the pain first started, as well as no significant past family history of colon cancer, inflammatory bowel disease, or other GI cancers. She also had a normal colonoscopy done at age 45. So as you are listening to this case and reading about this case, I want you to just keep in mind any details or symptoms that may sound familiar to you, whether it's something that you may have experienced or someone that may be experiencing. So what is IBS? So IBS is a very common gastrointestinal disorder that's chronic in nature. So that means that people who have IBS often deal with symptoms for several years, and it can take time to figure out the best management strategies for each person who has IBS. The two main characteristic symptoms of IBS are abdominal cramping or pain, as well as a change in bowel habits. So that may mean either becoming more constipated, having diarrhea, or having a mix of both. IBS is also a type of functional disorder, which means that it's a condition that relates to a disorder of the gut and the brain connection. The nerves in our gut are a part of a system called the enteric nervous system, and the system communicates with our brain. However, sometimes the nerves in our gut can become altered, become more sensitive, which then lead to changes in our symptoms, but there actually are no structural abnormalities that can be seen on tests, such as upper endoscopies, colonoscopies, or CT scans. So because the changes can't be seen structurally on a test like this, it can make it difficult to diagnose or understand a condition like IBS. But I hope that as we continue to go through this presentation, you'll be able to get a better understanding of what IBS is. Okay, so how common is IBS? Worldwide, it's estimated about 5 to 10% of the population have IBS. And within the United States, it's estimated about 12% of the population is affected by IBS. And it's also, as we mentioned, very common, as many of the referrals that we see in our GI department, about 25 to 50% of referrals are related to irritable bowel syndrome. And so, as you can see, it's quite common, and the symptoms, which we'll talk more about, can vary, and as well, so many people will seek out care to, help them manage these symptoms. And individuals who are more commonly affected by IBS are women, as 2/3 of people with IBS are women, as well as individuals less than 50 years old. However, this doesn't mean that if you're a man or if you're a bit older that you can't get IBS, but it's just more commonly found in women than younger individuals. So in terms of the symptoms, I already mentioned, abdominal cramping and pain, as well as changes in bowel habits are sort of the main symptoms related to IBS. The abdominal pain or cramping that someone can experience can vary in how they feel. It can be dull, it can be sharp. This pain can sort of come and go, and the location of pain can also vary between individuals, also within an individual as well. Often this pain is improved after a bowel movement, though there are some people who report that the pain does get worse with bowel movements. Also, things like emotional stress or eating can sometimes worsen the abdominal pain someone might feel. And with regards to sort of bowel habit changes, some people may become more constipated, which means stools can be harder, or they may have bowel movements that occur less frequently than 3 days a week, which would be constipation. Some patients with IBS have diarrhea, so the stools are more loose, they may be more frequent, having more than 3 in a day. Also, often patients with diarrhea often also report finding some mucus in their stools as well. Or some patients also have a mix of constipation and diarrhea, and they kind of go back and forth between the two. And bloating and gas are also other very common symptoms reported by patients with IBS. So what is the exact cause of IBS? At this time, we actually don't know the exact cause of IBS. However, there have been a lot of studies that have found many factors that can contribute to the development of IBS. So the first thing would be genetics. So if someone in your family has IBS, you may be more likely to develop IBS. Studies have also found that early life stress, so children who go through experiences of abuse or neglect, these can actually lead to changes in how their nerves develop, which can lead to changes in the perception of pain, especially later on in life. Other things like viral GI infections can also lead to changes in your gut microbiome, or also changes in the nerves in your GI system, leading to sort of changes in how you perceive pain and things like that. And also individuals with food sensitivities may also be more likely to develop irritable bowel syndrome. And so with these different factors, these can change sort of how our GI system, then processes these and causes different symptoms for people with IBS. So it can change sort of the changes in your muscle contraction in your GI system, the nerves in your gut may become more sensitive, as well as any changes in the motility and how your gut moves, which leads to things like the constipation or diarrhea that I mentioned previously. However, as I said, we still don't really fully know the cause, and so there's still more studies that need to be done to really fully understand the underlying causes of IBS.
So I'll jump in from here. This is Luyang. I'm happy to be part of this conversation as well. So in terms of diagnostics for IBS, initially the process will involve a detailed history taking where we gather information about your bowel habit changes and your symptom of abdominal pain. We'll ask about the onset, location, duration, characteristics, timing, and severity of the symptoms. We'll also ask you about your baseline frequency of bowel movements and compare it to your current frequency, whether this is any whether if there's any blood or tarry stool that you've seen, if you have straining or incomplete evacuation issue. Aside from that, we'll also ask you about your past medical history, surgical history, as well as your family history. Physical examinations will be done to help rule out some of the most obvious causes for some of your symptoms, but it's possible that it is possible for it to be normal. There are generally no specific tests that needs to be done or ordered by your provider, but oftentimes providers may consider getting some routine lab works done to rule out, for example, anemia, infection, to check your liver, kidney function, and your to see if there's any biliary abnormalities. So it is important to know the alarm symptoms that we look for, and as they may trigger a more extensive workup. So, for example, alarm symptoms are, being 50 or older, presenting with rectal bleeding with either bright red blood or dark tarry stool, nighttime bowel movements, including diarrhea, unintentional weight loss, family history of colon cancer, inflammatory bowel disease, or other GI cancer history. If you happen to have some recent lab works done prior to coming to the clinic, there's evidence of anemia or abnormal inflammatory markers, all of this information may alter the diagnostic approach that we will implement on you. So for our case, the physical examination for the patient was totally normal. It was benign and non-specific, which is expected for IBS patients. Can be expected for IBS patients. So patient was well-appearing female, that is alert and oriented to person, place, and time. The heart sounds normal, and the lungs are clear to auscultation. Patient was not in any acute distress. Her bowel sounds normal and present. Abdomen soft, non-tender to palpation, percussion. So now let's take a closer look at the room 4 diagnostic criteria and the Bristol stool chart. So these criteria are the foundation for diagnosing and categorizing subtypes for IBS. The diagnostic criteria include abdominal pain occurring at least once per week, along with 2 or more of the following symptoms. So they are: first, pain related to defecation; second, a change in frequency of bowel movements, and or a change in form or appearance of your bowel movements. So these symptoms must have been present for at least 3 months, and the onset of the symptoms at least 6 months before an official diagnosis can be made. Once a diagnosis is established, the next step is to categorize the subtype of IBS, which helps guide our treatment options. If you have predominantly type 1 or 2 stools on the chart for more than 25% of the time, you are considered to have IBS constipation predominant subtype. If you have more type 6 or 7 stools, then you're diagnosed with IBS-D, which stands for diarrhea. If you experience both type of stools for more than 25% of the time, you're considered to have the IBS mix subcategory. If your stool does not meet any of the criteria and does not have a clear pattern, you will be diagnosed with the unclassified IBS. The management will likely be based on where you fall on the spectrum at a specific time and what symptoms you are experiencing. So on paper, categorizing subtypes for IBS may seem very systematic and clear-cut. In reality, patients may sometimes have a harder time to accurately or correctly recall their stool pattern. So despite this challenge, once other causes of abdominal pain and change in bowel habit has been ruled out, we will be more certain this is IBS, and still treat it based on the most bothersome symptoms. So if you're having a diarrhea predominant presentation of IBS, providers will usually order a few additional labs to rule out common causes for chronic diarrhea. So One of the most common ones being celiac disease, which is an autoimmune disorder where ingestion of gluten can cause damage to the small intestines. It is one of the potential causes that we generally like to rule out. The gold standard for diagnosing celiac disease is via a upper endoscopy and duodenal biopsy. However, a non-invasive approach in this case or in this setting via a serology testing for TTG level is sufficient enough if it's negative. Another cause for diarrhea may be inflammatory bowel disease, especially if you have a positive family history of Crohn's or ulcerative colitis. In these cases, we usually like our patients to complete a stool test called fecal calprotectin, which is an inflammatory marker. It is a test. If the test is not available, other options may be considered, for example, fecal lactoferrin or even a blood test called CRP. If negative, then IBD is less likely the cause of the diarrhea. Also, based on the history taken from earlier, if there are concerns for infectious etiology, infectious causes, especially a history of recent travel to foreign countries, recent antibiotic use, hospital admissions, or even wilderness exposure, for example, hiking, drinking from a water source, stool labs for C. diff, a stool culture of a parasite, Giardia, and some other infectious lab works may be considered as well. Additionally, bile acid diarrhea may be another differential on our list. Bile acid is an irritant of the GI tract when they present in excess. This is common in patients with iliac resection procedure done in the past, which is the location where the bile salt is being reabsorbed back into our circulation. Or if patient had a recent cholecystectomy or their gallbladder removal, the gallbladder is considered the storage for our bile secretion, and without the storage, excessive bile can be excreted into the GI tract continuously and lead to potentially lead to diarrhea. Another condition called SIBO, or small intestinal bacterial overgrowth. So it is certainly another possibility. Like we discussed earlier, GI tract dysbiosis or imbalance of the bacteria in our gut can lead to diarrhea. Based on experience so far, different providers have different preferences for approaching this. Some may consider a trial of a medication called rifaximin. It is a non-absorbable antibiotics we commonly use to treat this condition to see if it helps with the symptom. While some other providers may like to do a breath testing first to confirm the diagnosis before treating. Other differential diagnoses include microscopic colitis, which require random colon biopsy to confirm the diagnosis, and this needs to be done with either a colonoscopy or a sigmoidoscopy. If alarm symptoms are present, such as rectal bleeding, anemia, weight loss, family history, concerning for colon cancer, we generally will pursue a colonoscopy right away to rule out malignancy. So on the other side, if you have a constipation predominant IBS, there are several tests and assessments we can perform to determine the root cause of your symptoms. During the physical exam, we may perform a digital rectal exam to assess for rectal tone, hemorrhoids problems, and potential causes for outlet obstruction. To further evaluate the extent of stool burden, we may utilize an X-ray of the abdomen to guide our constipation treatment. Additionally, an anorectal manometry test may be used to evaluate pelvic floor muscle dysfunction, dyssynergy, defecation. Depending on the results of the evaluation, we may recommend pelvic floor physical therapy or biofeedback therapy to help resolve your some of your constipation symptoms. For both conditions, like I mentioned earlier, if you are 45 or older and have not yet received your screening colonoscopy at this point, even without alarm symptoms, we may consider proceeding with a screening colonoscopy for screening purposes as well. But please note, the colonoscopy here is not part of the routine diagnostic unless it is indicated. So in our case, patient had some blood works done, CBC, BMP, they're normal. Celiac disease is negative by serology testing. Patient also had a normal colonoscopy that she's completed at age 45, so 5 years ago. Patient does not have any alarm symptoms reported during the history taking part of the assessment. This is the diagnostic so far we've done for the patient. So generally speaking, patient without alarm features with negative initial lab workups and meet the diagnostic criteria for IBS. Usually no additional testings are indicated, and we are generally pretty confident that about the confident about diagnosing patient with IBS, and with this approach, generally it will rule out some organic causes for 90% of the patients. So I wanted to share with you this latest recommendation from the American College of Gastroenterology, published in 2021. So these recommendations include some of the diagnostics that we discussed earlier already, as well as some treatment guidance that I'll talk about shortly. So some of the strong recommendations for diarrhea predominant patients include ruling out celiac disease via serology testing, testing fecal calprotectin to rule out IBD, and trying rifaximin for some of the IBS diarrhea predominant symptoms, predominant cases, and for treatment in general, strong recommendations include using soluble fiber supplements, prescribing secretagogue agents for IBS constipation patients, as well as consider using TCA tricyclic antidepressant agents for ongoing managements. So there are other recommendations on this list. Some are conditional, some are consensus recommendations, and they have different level of quality of evidence and may or may not be beneficial in practice. But they're worth knowing. Given the limited time for the day, I'll skip them for now. So for treatment, initial therapy. So when we're managing a chronic condition like IBS, we typically start with conservative measures such as lifestyle or dietary modifications, especially when symptoms are more mild or have minimum impact on quality of life. Research have shown that increasing physical activity can lead to improvements in IBS-related symptoms and can help prevent symptoms worsening. Dietary modifications can be challenging, but reducing or avoiding gas-producing foods like beans, onions, as well as decreasing alcohol or caffeine intake, is routinely recommended for every patient. Lactose avoidance may provide benefits as well, even if you are not considered lactose intolerant. Avoiding lactose sometimes can improve some of the GI symptoms. Gluten-free diets may also be helpful. Patients with negative celiac workup may still develop non-celiac gluten sensitivity, and therefore will be beneficial from a gluten-free diet. As we mentioned earlier, the American College of Gastroenterology recommendations recommended soluble fiber supplement as part of the treatment for IBS as well. Another thing, a special diet called low FODMAP diet has been shown to be very effective in controlling and managing many GI-related symptoms, especially in IBS patients. So FODMAPs are short-chain carbohydrates that are rapidly fermented in our GI tract. They can cause GI upsets, gas producing, can cause some bloating, and other IBS-like symptoms. Our body doesn't absorb them well, so excessive intake can exacerbate GI symptoms. I'll talk a little bit more about this diet in the next slide. So it is important to let patients know that IBS is a chronic condition, and there's no evidence to suggest by having this diagnosis or this condition, will increase risk for malignancy after the diagnosis. So it's essentially, it is important to discuss expectations and goals between the providers and the patients to achieve a better long-term management outcomes. So for low FODMAP diet, let's dive a little bit deeper into this special diet. So FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So essentially it represents a few common food categories, such as fruits, vegetables, starch, protein, and some of the artificial sweeteners. So high FODMAP diet, high FODMAP foods, it's bad and can exacerbate IBS symptoms, while low FODMAP food can be helpful and reduce or improve some of the GI symptoms. Some examples of high FODMAP food include apples, blackberries, avocados, broccoli, wheat-based bread, lentils, and artificial sweeteners. So some of these food, as you may notice, are generally considered healthy food, but still can potentially cause issues among patients. So the key to the low FODMAP diet is to follow it for a short period of time, usually between 2 to 6 weeks. So generally, we instruct our patients to eliminate some of the foods listed on the high FODMAP category to assess for any changes in symptoms. Then the patient can reintroduce these food items one at a time to identify specific triggers. Clinicians often need to pay extra attention to patients with history of eating disorders, as any sort of diet limitation can create new problems in this case. One of the leading institution researching the low FODMAP diet is the impact of the low FODMAP diet is Monash University from Australia. So they have created this website and beautiful phone app for a patient to use. It is very comprehensive and a helpful tool to sort of help patients through trial of the low FODMAP diet. So in terms of pharmacological treatment, so when initial conservative measures fail or patients have more moderate to severe symptoms, pharmacological therapy is usually introduced at this point. This typically is based on predominant symptoms of IBS. So for constipation predominant patients, most common over-the-counter options is polyethylene glycol or Marilax. This medication acts as a sponge to increase water content in the GI tract and facilitate bowel movements. Often we tell our patients to self-titrate up or down at home based on bowel movement results. Can start with 1 capful or 17 gram of the powder mixed with your beverage of choice. And usually it will produce some sort of improvement of the constipation symptoms. Prescription options for constipation include linaclotide, lubiprostone, and many other options that we may consider. they all function slightly different, but you can talk to your provider about some of these agents if you develop constipation and it's not managed well with some of the over the counter options. For diarrhea predominant patients, loperamide or Imodium is considered safe to use on as needed basis. If diarrhea is secondary to excessive bile acid production, cholestyramine may be used as well. So for the abdominal pain, antispasmodics agents like dicyclomine or hyoscyamine can be used for short-term relief. Can be used for short-term relief of the abdominal pain or bloating. And I mentioned earlier that TCAs like nortriptyline may be used to help with symptoms such as diarrhea or pain. But please note that we're not using this medication. We're not blaming your symptoms to psychiatric causes, but rather our GI tract and the brain respond to some of the same neuromodulation agents. So that's the reason why we're using some of these antidepressant or antipsychotic medications in this case. A trial of rifaximin I mentioned earlier, may be used for bloating. Currently there's no clear evidence on how different probiotics will affect your IBS symptoms, and generally speaking is not routinely recommended from our perspective. So another thing I wanted to mention here, so your providers may ask you about your bowel habit preference. So in this case, because the symptoms can vary between diarrhea and constipation, so probably they'll ask you questions like, if you get to pick between constipation and diarrhea, which one do you think you would prefer? Questions like this will help us gauge how far we should push towards one direction versus another in terms of treating your diarrhea or constipation. So in practice, for example, some patients would rather have diarrhea other than constipation because feeling backed up just too uncomfortable, whereas some other patients, they may prefer to have constipation as the frequency of bathroom visits is just very unbearable. Some other therapies here I listed include behavioral interventions like cognitive behavior therapy, other anxiolytic medications that your provider may consider as well as some alternative medicine options like acupuncture, yoga, tai chi. Sometimes peppermint oil tea products can provide some relief as well.
So to finish up our case, so our treatment plan for this patient, we will start by first increasing her physical activity, as that can help sort of, improve our gut motility and making those lifestyle changes. We also recommended to her trying the low FODMAP diet, looking at, in her diet, whether she incorporates any of those foods that may cause the bloating, constipation, those symptoms, or the diarrhea that she has, and seeing if that might be helpful for her. Also things like fiber supplements, things like Metamucil, Benefiber, or Citrusel, those can also be very helpful as well in helping bulking up the stool and improving the stool formation and preventing sort of that loose stool that she was experiencing before. Additionally, like we mentioned, there are medications called dicyclomine or hyoscyamine. These really are helpful for sort of short-term management for any abdominal pain or cramping, and they're typically used as an as-needed basis. And the side effect actually of constipation may indirectly provide some relief for patients with diarrhea. So for this patient with her diarrhea, this might be helpful for her in that aspect as well. Additionally, loperamide would be another good option to use. So usually we recommend this only kind of using on an as-needed basis. Hopefully things like fiber or other ways could help improve the diarrhea and not have to use Imodium all the time. And especially with a chronic condition like IBS, regular follow-ups for ongoing management is very important to make sure that she's continuing to make progress, or that if things are not going quite right, that we can, adjust what she's doing and provide other recommendations. And so some of the complications with IBS, as we mentioned, can affect individuals very differently. Some people have very mild symptoms, while others have very severe symptoms. And dealing with things like abdominal pain, irregular bowel habits, not knowing what each day will be like can cause a lot of stress and anxiety for many individuals with IBS. I've had patients express to me that they're afraid to leave the house, or they don't go anywhere unless they know exactly where the bathrooms are. And this can just lead to an overall impact and decrease in quality of their life, as IBS can really limit their ability to engage in social situations or other things that they might want to do. Additionally, dealing with symptoms of IBS can also affect one's work productivity. So just dealing with pain can make it difficult to focus. If you're in a meeting and worried about having to go to the bathroom in the middle of the meeting, can also make it, again, difficult to concentrate and just affects overall work productivity. And finally, because the symptoms of IBS can become very overwhelming and impacts many aspects of an individual's life, this can overall increase their risk of developing a psychological or mood disorder, which can further lead to a decrease in their quality of life. And so these effects, knowing that these things can happen with someone with IBS makes it so important for all of us to understand, what IBS is, and that there are ways that we can improve a patient's symptoms and overall quality of life. So just in summary, just to reiterate, IBS is a very common chronic functional GI disorder that's characterized by abdominal pain or discomfort, as well as a change in bowel habits. It's very common worldwide, affecting about 5 to 10% of the world's population. However, the exact cause of IBS is unknown, though we do have some idea of things that may influence or increase the risk of IBS. The ROM4 criteria is what us in GI use to diagnose IBS. And there are many labs, workups, or imaging that we might do to help rule out other causes of IBS before we sort of give that diagnosis of IBS to an individual. And treatments for IBS can be conservative in using sort of non-pharmacological measures like diet or lifestyle changes that can improve symptoms. However, for individuals with more severe symptoms, we may use more prescription medications that are based on the subtype of IBS that they have or predominant symptoms that they have. And again, just to reiterate, IBS plays a very major role in reducing quality of life for many individuals. It can also increase the risk of developing other mental health conditions. And so it's very important to, if you have symptoms like these, to talk to your primary care provider or GI provider, because as we mentioned, even though we can't see on testing something that specifically indicates IBS, that it doesn't mean that there isn't something we can do to improve your quality of life. So if you want to learn more about IBS, actually on the Mass General website, there is a specific page that goes over some of the things that we talked about IBS. Other resources you could use if you want to learn more about it would be the American College of Gastroenterology, as well as the American Gastroenterology Association. Those are also other great resources to use. I think that concludes our presentation today. We thank you all so much for coming, and we're also happy to take any questions that anyone has.
Thank you so much, Sarah and Luyang, for an informative presentation. We are now at the end of the session, so if you have any questions, feel free to enter them in the chat. Can you share a little bit more about what types of exercises can help with IBS?
Yeah, so generally speaking, there's no clear guidance on what type of exercise may help, but many other chronic conditions, from the cardiothoracic system, like exercise that may provide benefit to your cardiac system, can also provide some benefit in this case. Hopefully that helps.
Yeah, I would say things like aerobic exercise, like running, as well as we found that yoga or Tai Chi, those are also things that can help improve sort of overall, because as you exercise, it also increases your colon to start moving and being mobile. So, improving motility in that sense. And also things like yoga and Tai Chi can actually improve sort of resilience in people as well, and improving sort of the symptoms of pain related to that, and can also improve overall symptoms like that.
Thank you. You had mentioned peppermint oil, acupuncture, helping with IBS. Can you explain more a little bit about that and how that helps?
Yeah, that's a great question. The specifically for acupuncture, those are what we consider sort of complementary medicines. And so I don't think we fully understand the exact cause of how it improves IBS, but there have been studies that found that it can sort of approach pain in a different perspective than the ways we might approach it from the traditional medicines that we use. And those can just help be just another way that a lot of patients have found benefit with that can, sort of overall improve their quality of life.
Yeah, aside from that, I learned, perhaps the whole approach to alternative medicine, from a holistic point of view, may be also contributing to why it has been beneficial to treating some of these symptoms. Because after all, the IBS is a condition that affects the whole, essentially, it's a GI condition, but it affects the whole body. So, approaching that from, different point of view can offer some new perspective and new insights in terms of managing the condition.
Thank you. Can you share a little bit more about adding fiber to our diet and preventing IBS?
Yeah, so I think adding fiber definitely it can be helpful for both constipation and diarrhea. I will say it won't prevent IBS in terms of it's a condition that someone can develop. We don't know the cause of it, so just because you take fiber every day doesn't mean that you won't develop IBS. But fiber can really help improve the overall sort of symptom as opposed specifically with constipation and diarrhea and improving sort of stool consistency. And so what things like psyllium husk can do is it's actually a soluble type of fiber. And what it does is when you take something like psyllium husk, it actually creates a gel in your stool that improves sort of stool consistency. So if your stools are very hard, it can actually, allow the stool to become more softer if you take something like psyllium husk. And then with patients who may have more looser stools or diarrhea, it actually helps increase and create some sort of form within, the stool, and so overall helping improving stool consistency.
Thank you. For a patient with IBS, what would a typical visit look like for someone who would be seen at Mass General?
Yeah, so for this type of visit, usually a patient doesn't come in with a established diagnosis. They may present with, for example, I've been having chronic abdominal pain, or I've been having constipation issues for many months now, or I've been having chronic diarrhea. So like we talked a little bit earlier during the presentation, we usually start pretty broad. We take a good detailed history, just to gather all the necessary information. Essentially, we want to rule out some of the obvious causes for some of your symptoms, whether it was because your diet did not consist with a lot of fiber that's been causing you to have constipation, or maybe you had a recent antibiotics, had a course of antibiotics that's been causing you to have diarrhea. So examples like this, we are trying to rule out during our initial visits. And then, we may consider doing lab works as well to rule out, for example, the celiac disease that may or may not be contributing to your symptoms, as well as some of the imaging options that we can do to assess for stool burden. So yeah, so essentially the initial visit will be pretty comprehensive. Essentially, the main purpose is gather more information and then help us rule out and rule in some of these common diagnoses.
Are you located on the main campus in Boston, or do you have other sites?
So my understanding is we both of us are practicing from the main campus in downtown Boston, but we do have some satellite offices where some of our providers can see patients at. If you have additional questions about scheduling appointments, or just general questions, you can you are always welcome to call our office. Yeah.
Thank you so much. So I think that's all the questions that we have for today. Before we end today's session, do you have any final thoughts you'd like to share with the audience?
Yeah, well, I mean, I appreciate everyone who's here listening to our talk, and I think, you know, the biggest takeaway for me, especially because, you know, I was learning about IBS and, you know, understanding this condition, just knowing that even though, you know, we don't see, you know, something on imaging that's causing your pain doesn't mean that we don't believe your pain is real. I think often people, you know, they go through this whole workup and they think, oh, well, my doctor doesn't know what I have, so I have IBS. And it's not actually, you know, what it is. It's not that we don't know. We think we just have to rule out all the other causes, because treating those other causes is different than the way we approach someone with IBS. And so the pain or the different symptoms you experience are all very real. We definitely understand that. And we just also want people to know that there are ways that we can, you know, help you improving your quality of life through pain or through improving stool, you know, how your bowel habits are, and that there are ways that we can do to improve that.
Yeah, also just to add, you know, we have a very supportive team, you know, with all of our APPs, as well as some of these amazing attending doctors that can offer different options for managing some conditions like IBS here. Yeah. So definitely, yeah. We'll be able to help. You know, if you do have some of the symptoms, or you've been suffering from, you know, some of the symptoms we talked about today, you know, we definitely will be able to offer some additional help.
Great. Well, thank you so much for your time. Today's session was very informative. And for everyone who took the time to join us today, thank you so much. As I had mentioned, today's session is being recorded. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.